So I hope everybody can see me, and welcome to this class on contraceptives. These are my notes that I have made mostly after reading, and I've made these from all the standard books and all the recent advances also included in them. They're included from all the guidelines, but yes, I've definitely used ChatGPT to help me make everything in the form of tables so that everything is very easy to understand and everything is very easy to memorize. So the first thing that we will start with, uh, if my pen malfunctions or if my notes or if my laptop malfunctions, I am sorry about that. Uh, the first thing we will start with will be OCPs and progesterone only pills. If you need these notes, you can definitely contact me on Telegram or healing or on my Instagram. I'll provide the links below. So I will provide the notes for them. So combined, COCs that are combined pills, they contain estrogen, which is ethinyl estradiol, and progesterone. Most common ethinyl estrogen dose is 30 microgram, and low dose pills can have 20. They can also, ultra low can have 10. So the minimum effective estrogen dose is 10 microgram. Now what happens is that if some person is taking anti-epileptic drugs, these are enzyme inducing. So what will happen is that they will metabolize the estrogen, which will decrease the effectiveness. Therefore, in such people, we have to give high dose estrogen, which is 50 microgram. So high dose will not trigger the seizures, so progesterone only pills can be considered as alternative. Now, the first thing that I want you guys to know is the comparison of the progesterone generations, first to fourth. This is very confusing. Sometimes we can't memorize the names. So first generation, this is divided into. Also, I'd like to mention one thing, that I've also, some of my sources are also from the Speed SS notes. So I will give credit to them also. Uh, all these notes are just a mixture of different sources I've used, and now I can't even remember the sources I've used, but definitely I have watched the Speed SS videos and taken some points from them also. That is there. Okay, so the first generation, norethistron acetate, very easy, and linestrol. Alright, now the thing is, these are androgenic, these are also atherogenic. They're the worst, basically they're the worst type of progesterone. Atherogenic also, they will increase your LDL, they will decrease your HDL, but they do not cause DVT. How they are obsolete mostly in OCPs because they can cause acne, hirsutism, lipid derangement, because they are androgenic as well as atherogenic, right? Then we have levonorgestrel and norgestrel. Levonorgestrel, you know that it is very commonly used. Now it is mild androgenic. Lipid profile is poor, as in it will decrease your HDL, increase. It is not that great. There are no additional risks of DVT. It is high in Mala N, as you know. It is definitely Mala N it is used. So in Mala N, levonorgestrel is used, and Mala D, D-norgestrel is used. Third generation is desogestrel, gestodine, norgestimate. Desogestrel, norgestimate, and gestodine. Things where there are more G's. This is how I have memorized them. Desogestrel, gestodine, norgestimate. They have no androgenic activity. They are lipid friendly. There is some DVT risk, which is paradoxical. However, so they have a little venous thrombosis risk, but they have a better metabolic profile. The best is drospiron, cyproteron acetate, and dinogest. These are very common drugs that you must have heard. These are anti-androgenic. They're even better. They're anti-androgenic, lipid friendly, no added risk. They're ideal for acne, PCOS, hirsutism. Drospiron plus ethinyl estradiol is common in modern OCPs. So third generations have an increased risk of DVT. Fourth generation have the best balance: drospiron, cyproteron acetate, anti-androgenic, dinogest, which you know that is used in endometriosis. Now I want you to know all the brand names also, and I want you to know their composition also, because they will hand them to you in the Viva, and sometimes the brain doesn't work that look at the drug composition which is given on top of that. Sometimes it is even hidden in the Viva. So Mala N, we know, ethinyl estradiol 30, levonorgestrel. Mala D, same D. So these are using what? Second generation. These are second generation progestins. Mala N is free of cost. D, do paisa, that is not free of cost. Okay, so Mala N is free of cost. Then we have Femilon. Femilon is low estrogen, low dose OCP. It is lipid friendly, but as we know, it has desogestrel, which is third generation. So there is, with estrogen, along with estrogen and progesterone and third generation, there is an increased DVT risk. Then we have Yasmin, Tarama, and Andronis. It is 30 mg. Most of them contain 30. The maximum estrogen that I know of is Dianet, which has 35. So cyproterone acetate 2 mg or 3 mg. So potent anti-androgen hirsutism, slightly, there is no, this is wrong, there is no increased DVT risk. The increased DVT risk is only because of the increased estrogen, not because of the progesterone. So don't get confused here. So mechanism of action. Now I want you to know and go back to your gynae physiology. Estrogen in high dose, what does it do? Estrogen in low dose inhibits LH as well as FSH. In high dose, it causes the LH surge. So progesterone, but basically estrogen will inhibit FSH, progesterone will all inhibit LH, both anterior pituitary. So FSH will not cause any follicular recruitment, it will not cause any follicular growth, no dominant follicle will be formed. If LH is inhibited, no LH surge, no ovulation. Alright. So additional mechanisms is that what progesterone does, it does endometrial atrophy. So progesterone, so the environment will be unfavorable for implantation. Then we have cervical mucus thickening, again by progesterone, sperm penetration barrier. So basically what happens is that it has high efficacy, 0.1 to 0.2 per 100 human women years. Now anything you have to know, if it is inhibiting ovulation, one basic golden rule in if you have to memorize in contraceptives is that if any contraceptive is preventing ovulation, it is preventing ectopic pregnancy. Alright. Also, they will reduce ovarian cancer risk if no ovulation is happening. Hence, there will be less of gonadotrophin stimulation of the ovary. So, it reduces ovarian cancer risk. No ovulation, no ovum, no ectopic. So, this is the golden rule. So, we will go through some important points. Failure rate 0.1 to 0.2 per 100 women years. Risk of ectopic pregnancy is decreased. Cycle regularity is improved. It is used in PCOS. It is used to normalize the cycle frequency. Effect on flow volume, decreases flow, hypomenorrhea, because we are going through anovulatory cycles, right? Treatment for PMS, yes, if there is no ovulation, there will be decreased hormonal fluctuation. For Mittelmarsh, yes, because of no ovulation, so no mid-cycle prostaglandin surge. Primary dysmenorrhea, yes, because it will prevent the prostaglandin release from the corpus luteum. Protection against ovarian cancer, yes. Protection against endometrial cancer, again, yes, because progesterone is causing endometrial atrophy. Now, but so what does it decrease the risk of? Ovarian cancer. And 1 year use risk decreases the risk for what? How many years? It decreases the risk for 10 years. Then endometrial cancer, same as above, lasting protection after discontinuation. Colorectal cancer, modest but consistent risk reduction. Okay, we're back. So modest but consistent risk reduction. Benign breast disease, fibroadenoma, decreases adenosis. Pelvic inflammatory disease is also reduced because thick cervical mucus barrier prevents the ascent of all these infections. But they increase the risk of breast cancer, and you'll be like, oh no, but we just read that benign breast diseases are decreased. So it only reduces the risk of benign breast diseases like fibroadenoma and fibroadenosis, but breast cancer risk increases during use. Risk returns to baseline after continuation. Benign hepatic adenoma increases the risk. No increased risk in hepatocellular carcinoma. Now chlamydial PID. Now the thing is that because of the cervical ectopy and mucus changes, there is susceptibility to chlamydia. There is decreased risk of pelvic inflammatory disease, but there is increased risk of chlamydial PID. So preferred time to start is day 1 of the menstrual cycle. No backup is needed. Alternative, you start within the first 5 days of your cycle. This has been taken from Speed notes. So basically she can start up to any day up to day 5. She does not need additional contraceptives, and she does not need to check for she does not yeah, so basically she does not need any additional and she does not have to check for pregnancy. But if she takes it at any other time, she's not pregnant or UPT is negative, then she will require additional contraceptives, and you can consider doing a UPT. Now I don't know what HSUPT is. Forgive me, I have forgotten what HSUPT is. But anyway, I'll look into it, and then anyway, so it is UPT only. Now I don't know what the HS means, but it's okay. Women who are don't come at me, guys. I am still learning this. I am just making this video so that I can learn for my exams, not for you. This is for me. So dosage schedule: taken once daily at bedtime to reduce nausea, 21 days and 7 days. You all know this. But what you don't know is, as in what is mostly new for us, is these are the FRSH guidelines. Thank you, Speed. Thank you, Revati ma'am. You are great. You are amazing, and I owe everything to you for this exam. Women who are amenorrheic, anytime if she's certain she's not pregnant and UPT is negative, yes. After LNG, immediately after UPAEC, she can take 5 days after taking UPAEC. After childbirth, from 6 weeks following childbirth, after childbirth, if she's breastfeeding, 6 weeks. If she's not breastfeeding and she does not have any additional risk factors, 3 weeks following breastfeeding, she will still require additional contraceptive for 7 days, and if 9 days for estrogen, Valerate, Dynogest. Okay, or Dynogest. Estrogen, remember this, 9 days for estradiol, Valerate, and or Dynogest. Okay, so if she is within up to 5 days, no need for any other contraceptive. But any other thing, if she's amenorrheic or immediately after LNG, immediately after UPA, after childbirth, after breastfeeding, 6 weeks after breastfeeding, no, she's not after childbirth, not breastfeeding, 3 weeks. But if she does not have any additional risk factor. Now there is a pill-free interval, 7 days. If it is more than 7 days, then efficacy will decrease, ovulation may occur. No periods, even if she does not, there will be women who will come to you that I have not gotten periods, so I did not start. Start next pack after 7 days, those 7 days of the pill-free period, and do urine pregnancy test. Iron tablets are included for 7 days. These are non-hormonal. Now there's a mist pill. Where is it? There is a mist pill guideline, and I think that question also comes, and I have included that somewhere in my notes. Let me just find it, and then I can, yeah, here. So if she has missed one pill, take the missed pill as soon as possible and resume schedule. Backup is not. One is, if she comes to you and she's like, yesterday's pill I did, you tell her that take the missed pill as soon as possible. No need for backup, and resume your schedule. If she has missed 2 pills, now if it is during week 1 or 2, she has to take 2 pills daily for 2 days and then finish the pack. Backup is not likely needed. So for 2 days, you tell her take 2 pills and then finish the pack as usual, and then backup is not needed but advised for 7 days. Now this is during the first or second week. Now if she is during week 3, now some women like to start it on a Sunday, so they are called Sunday start, and women who take it from the day first of their menses, they are day 1. So Sunday start means the day their period came, then the Sunday that has started, they will take it on that. So day 1 start a new pack. immediately use backup for 7 days. Take the daily pill till Sunday, then start a new pack, and then immediately use backup for 7 days. Now there'll be patients who come to you who will have 3 or more pills missed. So if she's day 1, this is similar. Start a new pack, use backup immediately for 7 days. This is also similar. Take daily pill. Basically, if she is a day 1 start, there is no concept of weeks here. If which week was she did it in. If she has missed 3 or more pills, just you have to stop using the pack that you are using. Start a new pack, and for 7 days use backup. Sunday start, take a daily pill till Sunday, then start a new pack and use backup for 7 days. So this was about the missed pill. I'm sorry, where did I? So now there are some contraindications. We know WHO MEC, medical eligibility criteria. So postpartum less than 6 weeks, now also you have to know what is contraindication for COC is actually the indication for an IUCD. So remember that. So postpartum less than 6 weeks less than 6 weeks breastfeeding, less than 3 weeks VTE risk, not breastfeeding, uncontrolled hypertension, ischemic heart disease, stroke, complicated valvular heart disease, cardiomyopathy, atrial fibrillation. This is cardiovascular. Then thromboembolism, if she was current or past VTE on anticoagulation, major surgery, known thrombogenic mutation, protein C, S, AT deficiency, smoking, age more than equal to 35 years, more than equal to 15 cigarettes per day, neurological, migraine with aura, breast, current breast cancer, liver, severe decompensated cirrhosis, hepatic adenoma, acute viral hepatitis, autoimmune SLE positive APLA antibodies, APLA, because they are also prone to thrombosis, so they can also have VTE. So what do we have? Postpartum, cardiovascular, whatever you remember, the bad things, cardiovascular, just add it in that. Uncontrolled hypertension, ischemic heart disease, stroke, complicated valvular disease, cardiomyopathy with impaired ejection fraction, atrial. Then thromboembolism, if she's current or past venous thromboembolism on anticoagulation, major surgery with immobilization, known thrombogenic mutation, age more than 35. Then smoking, age more than equal to 35 years, and she uses more than 15 cigarettes per day, neurological, migraine with aura, any age, current breast cancer, no, we can't give it to her. Liver, so don't just prescribe OCPs to patients. Actually ask the history. They might not give you the history because they don't know. So when you are prescribing all of these, there is rampant prescription of OCPs these days. So before that, do check and take proper history. Not just ruling out pregnancy, but you have to rule out all of this also. Current breast cancer, liver, cirrhosis, hepatic adenoma, acute viral hepatitis, autoimmune, SLE with positive APLA antibodies, APLA syndrome. Now there is also, so this was absolute contraindication. Now there is category 3 where the risk is more than the benefit, and we have to use with caution. If non-breastfeeding less than 3 weeks with VTE risk factors, controlled hypertension, this is almost as in there is a connection with the category 4. Smoking, age more than 35, less than 15, or she's an ex-smoker less than 5 months. Now past history of breast cancer, BRCA1 or 2 mutation, undiagnosed breast lumps or symptoms, liver, gallbladder, compensated cirrhosis, gallbladder disease, organ transplant, cardiac allograft, vasculopathy, graft failure, neurological, migraine without aura, obesity, BMI more than 35 kg per meter square, especially post-bariatric surgery, diabetes, vasculopathy, mobility, she is wheelchair bound, debilitating illness, and there is history of VTE in the family. So this is the OCP part. I hope I have done justice to it. This is all for this video. Next contraceptive will be in a different video because it's very difficult for me to upload all of them together. So this is just about the OCPs. I hope everybody understood, and I hope all of you have a good time. All the best to you if you have exams, and thank you very much and good night.